Hello and welcome to another Chapter 38 video, and we are going to discuss disorders of the liver, gallbladder, and pancreas in this video. And we're going to start off with acute liver failure. And we can also call this fulminant liver failure. And whenever we see that word fulminant, we want to think of a process that has happened suddenly or is escalating quickly and is becoming severe. So this is pretty rare and it results in severe impairment or necrosis of the liver cells without pre-existing liver disease or cirrhosis. And so this typically takes place when acetaminophen overdose takes place and can also occur concurrent with liver disease such as viral hepatitis or metabolic liver disorders. And we're going to look for some initial signs of anorexia, vomiting, abdominal pain, and progressive jaundice. And this could be followed by ascites, GI bleeding, and then hepatic encephalopathy. To diagnose this, we would do some liver function tests, and for treatment, we can give N-acetylcysteine for detoxification, and it should be given as soon as possible, hopefully within 16 hours after the acetaminophen was taken. And hopefully we can do this before hepatic necrosis takes place because that is irreversible. And so if needed, we could do a liver transplantation, and artificial liver support devices are also available to help bridge transplantation. Now let's talk about cirrhosis. This is going to be an irreversible inflammatory fibrotic liver disease, and there are so many causes of this. Mainly hepatitis B and C, excessive alcohol intake is really common, having it be idiopathic is common as well, and then we can develop things like non-alcoholic fatty liver disease, also known as non-alcoholic steatohepatitis, and autoimmune disorders. And we don't really understand the pathophysiology mechanisms, but we do know that there are structural changes that take place due to injury and fibrosis taking place, and we get an infiltration of our leukocytes and some inflammatory mediators that are going to activate the fibrotic processes, which then are going to plug up the biliary channels that could lead to jaundice and portal hypertension. And you could see the progression over here because we've got those formations of the fibrous bands. We have nodules that start to distort the architecture of the liver, and it gives it this cobbly appearance. Now here we see the clinical manifestations of cirrhosis, and we start off with liver inflammation, which causes these symptoms over here like pain, fever, nausea, vomiting, anorexia, and fatigue. But this, as it advances, can lead to liver necrosis. Now you could see a slew of manifestations taking place after that. And we've discussed a lot of these in our previous video where we talked about complications of liver disease. So I won't go through a repeat of that. And then from liver necrosis, we are going to go into liver fibrosis and scarring, which is going to cause portal hypertension as we start to build up the pressure within the venous system. That can then lead to ascites, edema, splenomegaly, and varices. So as you can see, cirrhosis is a multi-system disease, and it's causing all sorts of manifestations that are increasing the risk of death. And we also increase our risk of hepatocellular carcinoma, which also can lead to death. Let's talk about alcoholic liver disease. This is related to toxic effects of alcohol and coexisting liver disease. And we have a few different forms. We'll start off with alcoholic fatty liver, which is the mildest form, and it could be caused by just small amounts of alcohol. So typically it's asymptomatic and luckily reversible. But we do start to see an increase in lipogenesis, cholesterol synthesis within the hepatocytes that can then cause lipid to be deposited within the liver tissue. And then we have our alcoholic steatohepatitis, also known as alcoholic hepatitis, and you see that pictured over here. And this really is a precursor to cirrhosis, where we're also seeing increases in fat storage, inflammation, and we start to get degeneration and necrosis of the hepatocytes, which then stimulate an irreversible fibrosis of the liver. And we also get the immune cells of neutrophils and lymphocytes infiltrating the tissue. So as we start to increase the fatty infiltration, we are going to see clinical manifestations of anorexia, nausea, jaundice, and edema. Then we've got our alcoholic cirrhosis, where we are getting some oxidative stress developing and a release of inflammatory cytokines, and our hepatocytes are now losing their function, and the stellate cells here become activated and start to contribute to collagen formation and more liver fibrosis. Now, in relation to alcohol consumption, the acetaldehyde inhibits the export of proteins from the liver, and so we're going to alter the metabolism of vitamins and minerals as well, and we can induce malnutrition in this way. And we also have the complication of the fibrosis and scarring starting to cause obstruction to the biliary ducts and vascular channels. Now, what about non-alcoholic fatty liver disease? This we usually see is associated with obesity, including obese children, high levels of cholesterol and triglycerides, metabolic syndrome, and people who have type 2 diabetes. And it can cause infiltration of the hepatocytes with fat, even though we don't have any alcohol intake taking place. And it can develop into non-alcoholic steatohepatitis with hepatocellular injury, inflammation, and fibrosis taking place, which is usually going to be asymptomatic. And from there, it could progress to cirrhosis and end-stage liver disease. The treatment is individualized and can include use of behavioral modification, dietary counseling, and regular exercise. Now on to primary biliary cholangitis. This is going to be a chronic, slowly progressive autoimmune cholestatic liver disease, and it begins in the bile canaliculi and the bile ducts. And the destruction is going to be caused by autoimmune T cells that are highly specific to anti-mitochondrial antibody destruction of the small intrahepatic bile ducts. So as they branch, they become smaller and smaller, right? And as that destruction takes place, we get inflammation, fibrosis, and eventually obstruction of these bile ducts. That can then bring about some clinical manifestations of pruritus, and these are kind of progressing as we go. Then we get hyperbilirubinemia, jaundice, and a light clay-colored stool. This can then progress into cirrhosis, portal hypertension, and encephalopathy. And sadly, the life expectancy is only 5 to 10 years after the onset of symptoms. So for treatment, we want to use ursodeoxycholic acid to slow the progression of this, or we can do a liver transplant. On to viral hepatitis. This is going to be a systemic viral disease that primarily is going to affect the liver, and we do have 5 different types: A, B, C, D, and E. And hepatitis A was formerly known as infectious hepatitis, and hepatitis B was formerly known as serum hepatitis. And this viral disease is going to cause pathologic lesions that can include hepatic cell necrosis, scarring if it is a chronic disease, and those Kupffer cells can become hyperplastic. So we start to get infiltration of our phagocytes as severity increases, and we've got cell-mediated immune reactions that trigger the inflammatory process and damage and obstruct the bile canaliculi, which can then lead to cholestasis and obstructive jaundice. So we've got a spectrum of manifestations depending on the severity of the hepatitis. We might have no symptoms to fulminating hepatitis with a rapid onset of liver failure and coma. Now, this takes place as a clinical course through 3 phases, and it is preceded by our incubation phase, which you could see here as far as its duration. And remember that this is the phase when we are first infected to the appearance of the very first symptom. And this is going to vary because of the 5 different types that we have. So we'll start talking about the prodromal phase, and this is going to begin about 2 weeks after exposure, but can range, of course. And we see the appearance of jaundice and the Patient is usually feeling fatigued, anorexic, malaise, has feelings of nausea, vomiting may take place, headaches, hyperalgia, cough, and a low-grade fever. And at this point, the virus is highly transmissible. The icteric phase can begin about 1 to 2 weeks after the prodromal phase and can last about 2 to 6 weeks. And we are going to still see jaundice taking place, maybe some dark urine and clay-colored stools, and the liver becomes enlarged and tender. So this is our actual phase of illness that's taking place. And then we want to move into our convalescence or recovery phase. And this begins once jaundice is no longer present and our symptoms are starting to diminish, although our liver can still remain enlarged and tender, but we see that our liver function returns to normal in about 2 to 12 weeks after the onset of jaundice took place. Now let's talk about chronic active hepatitis. This is when we have the acute stages of either hepatitis B, C, or a co-infection of hepatitis B and D persist and continue to cause clinical manifestations and liver inflammation. And this predisposes us to having cirrhosis and primary hepatocellular carcinoma. And this is diagnosed if we have those liver function tests remain abnormal after 6 or more months. And for treatment, it's really going to vary depending on which type we have, but we want to restrict physical activity and stick to a low-fat, high-carb diet, especially if that bile flow is obstructed. And our goal is to suppress the viral replication before we start to damage the liver irreversibly. Now let's move into disorders of the gallbladder, and usually these types of disorders are going to have to do with obstruction or inflammation. And we'll first talk about the obstruction sort, and that's when we develop gallstones. And when they form, we call this cholelithiasis. And our risk factors are going to be obesity, middle age, female, taking oral contraceptives, having rapid weight loss, having a Native American ancestry, a genetic predisposition, or gallbladder, pancreas, or ileal disease. And so when we have these gallstones form, they can become lodged into the cystic duct and obstruct that flow of bile into and out of the gallbladder. And this can then cause inflammation. And I mentioned the risk factor of being of Native American ancestry, and we see that about 60 to 70% of patients have this attribute. Now, these gallstones are formed from impaired metabolism of cholesterol, bilirubin, and bile acids. And they're going to vary in chemical composition. We can see that gallstones are going to contain cholesterol, unconjugated bilirubin, calcium salts, fatty acids, calcium carbonates and phosphates, and mucin glycoproteins. And we can really break this down into 3 separate types. We've got our cholesterol, which are cholesterol stones, which are the most common, and they're made up of 70 to 80% cholesterol, and they're formed from bile that is supersaturated with cholesterol, which really sets the stage for cholesterol crystal formation to form these stones. Then we've got our pigmented brown stones, which have less than 30% cholesterol, and these are formed by calcium bilirubinate and fatty acid soaps that bind with the calcium. And these stones are associated with biliary stasis, bacterial infections, and biliary parasites. And the black stones are going to also be less than 30% cholesterol, and these are very rare, but they're composed of calcium bilirubinate and with mucin glycoproteins and are associated with chronic liver disease and hemolytic disease. And you could see some of the examples of what these stones look like down here, and you could see the percentages of how much cholesterol is in each of them. And as these gallstones form, they can accumulate and fill the entire gallbladder, and our clinical manifestations are often asymptomatic or vague. These vague symptoms could be heartburn, flatulence, epigastric discomfort, and food intolerances, especially if it is a fat, to which the gallbladder is then going to want to secrete bile. And that pain that we might feel can occur 30 minutes to several hours after we eat a fatty meal, and the pain can radiate to the mid-upper area of the back as well. And because we have an obstruction of those bile ducts, we can have jaundice develop, which typically is a sign that that stone is found within the common bile duct. And that for sure is going to prompt someone to go seek medical treatment. So to diagnose this, we can use an oral cholecystogram that can outline the stones, or we could do an intravenous cholangiography that allows us to use a contrast material that is injected into the bloodstream and taken up by the liver, so that we can look at the larger bile ducts within the liver and the bile ducts outside of the liver as well. We can also use a endoscopic or transabdominal ultrasound, and for treatment we could use oral bile acid so that we can prevent or dissolve the cholesterol stones. We can reduce polyunsaturated and monosaturated fat and caffeine intake, increase our fiber in our diet, and a endoscopic removal of the stone, or extracorporeal shock wave lithotripsy that could break down larger stones into smaller ones so they can pass through. And sometimes cholelithiasis and cholecystitis go hand in hand. This is when we're going to have an inflammation of the gallbladder or that cystic duct, and comes about when we have a gallstone that's lodged into that cystic duct. We know that the obstruction can become distended and inflamed, and the stones start to put pressure on the gallbladder wall, and that could cause ischemia by pushing on the blood vessels that supply that area, that can then lead to necrosis and perforation. So the pain that they feel is similar to that caused by gallstones and can include fever, leukocytosis, rebound tenderness, and abdominal muscle guarding when we are tensing the abdominal wall muscles to guard the inflamed organs. Now, when we have an obstruction, that could also lead to reflux of bile into the pancreatic duct and cause acute pancreatitis. To diagnose and treat this, we're going to have some similarities to when we have gallstones present. We could use narcotics for pain, and if there's a bacterial infection, we can use antibiotics. And if it's really persistent, we can do a cholecystectomy where we remove the gallbladder. So now let's move into disorders of the pancreas, and mainly we're going to talk about pancreatitis here, which is going to be inflammation of the pancreas. This is a rare disease in which if you have risk factors such as obstructive biliary tract disease, alcoholism, obesity, peptic ulcers, trauma, hyperlipidemia, hypercalcemia, smoking, certain drugs and genetic factors, you can develop pancreatitis. So that does seem like a lot. But mainly this disease is going to develop because there's obstruction of the outflow of the pancreatic digestive enzymes caused by bile or the pancreatic duct to become obstructed. So we have two different forms, acute and chronic. So we're going to spend quite a bit of time on this slide. First, starting off with acute pancreatitis, and this is usually mild and can resolve spontaneously, although 20% of these cases turn into a severe condition that requires hospitalization. And this can first result from direct cellular injury from alcohol, drugs, or a viral infection. And again, basically because we've got an obstruction of that outflow of the pancreatic digestive enzymes, that's then going to cause bile and the pancreatic juices to back up, and the pancreatic secretions then activate the pancreatic enzymes in the acinar cells and cause autodigestion that then leads to inflammation, vascular damage, coagulation, and fat necrosis. We can also get some edema within the pancreatic capsule that can then cause ischemia and necrosis. Now, if alcohol abuse is present, we can also form some protein plugs within these ducts that can cause spasms of the hepatopancreatic sphincter that leads to obstruction as well. So some of the cardinal manifestations are epigastric or mid-abdominal constant pain, and we can also have some systemic effects from the release of pro-inflammatory cytokines causing vasodilation, hypotension, and then into shock. To diagnose this, we want to look at elevated serum lipase levels. And for treatment, we can use narcotics for pain and adjust the diet to allow the pancreas to rest. We can give parenteral fluids, and if there's infection, we need antibiotics. Now let's move into chronic pancreatitis, and this is going to be a progressive fibrotic destruction of the pancreas. And it's really related to chronic alcohol abuse. So we start to get the pancreatic parenchyma destruction, and it starts to be replaced by fibrous tissue, strictures, calcification, which you see pictured here, ductal obstruction, and pancreatic cysts that can then cause continuous or intermittent abdominal pain and weight loss. And to best manage this, we want to decrease or completely stop alcohol intake, really. And we know that that's important in both acute and chronic pancreatitis. And if not, this can progress and become a risk factor for pancreatic cancer. To treat this, there are many different methods. We can do endoscopic or surgical drainage of the cysts, or partial resection of the pancreas may be required so we can relieve some of the pain and possibly prevent cystic rupture.